effective and gratifying relationships. So, realistic self-knowledge, realistic knowledge of others, gratifying relationships, and general flexibility of behavior, so that in spite of one's habitual behavior pattern, we're able to modify and correct behavior patterns in terms of immediate social reality, indicate normality. How do we evaluate it practically, clinically? By asking patients how they function in 3 major areas of their life. How they function in work and profession, in love and sex, in social life and creativity. Work and profession means whether one is able to work or study, be satisfied, be successful, live up to one's potential and be gratified by it. Love and sex, if there is a capacity for full and free development of all sexual functions, integrate them with the capacity for tenderness and intimacy. In other words, the integration between erotism and love. In the social realm, the capacity to have friendships, intimacy with friends, gratifying and effective relation with friends and family, and creativity in the sense of finding areas in which one can be gratified and happy with a personal interest that in itself absorbs one regardless of its function, without it having a function simply of self-aggrandizement. So that's in essence normal personality. What are personality disorders? Personality disorders are inhibitions, limitations in that capacity of functioning. They show in the rigidity of character patterns. The most important symptom of personality disorders are rigidity of habitual behavior pattern. That means that the individual has what we call pathological character traits, meaning certain patterns of behavior that are employed when they are functional and when they are not. They're like an old shoe that has to be resorted to again and again, limiting the capacity of adaptation, both in work and love and social life in all the major, and creativity in the major areas that I refer to. Those rigidities can be classified into 3 types. Inhibitions, in the sense that there are rigidities in which some normal functions are curtailed. An individual can develop normal sexual behavior except his incapacity to have sexual relations with the person that individual loves. An individual can speak freely except in a group situation in which he can't speak up. Infinite forms of inhibitory character traits. A second type of character traits are so-called reaction formation or reactive character traits, in which the opposite of conflictual, of feared behavior determines exaggerated behavior. A person defends against sexual impulses by becoming pseudo-hypersexual. Exhibitionism as a defense against underlying fearfulness about sexuality. An excessive friendliness as a defense against aggressive impulses typical for obsessive-compulsive personalities. So we have inhibitory traits, reaction formation, and chaotic combination of both that are typical of the more severe personality disorders, where the individual oscillates between opposite aspects of rigid traits. These are first symptoms of unresolved issues in the adaptation to self and the environment. Second, typical as a consequence of these traits is a reduction in the capacity of effectiveness and gratification in those three major areas that I mentioned. Third, and this becomes a crucial differentiation, there are two general levels of personality disorders. Those that we operate at a neurotic level, neurotic personality organization, in which we have such rigidities, but with a maintenance of an integrated sense of self and integrated views of significant others. And another type of personality disorder, the more severe personality disorders that we call borderline personality organization, not to be confused with borderline personality disorder as a specific type of severe personality disorder at that more severe level. Borderline personality organization characterized by the lack of integration of the concept of the self and lack of integration of the concept of significant others. These more severe personality disorders are related basically to a fundamental etiological feature, a predominance of the aggressive, negative aspect of internalized experience of relation with significant others that I mentioned earlier. In other words, the normal integration between an idealized and a persecutory segment of experience cannot occur because there has been such a predominance of the development of a negative experience of relation between self and others that there is a fear that any effort of integration will mean swamping psychic experience with negative experiences of self and others and create an impossible world. And in order to survive, there is a need for keeping separate an idealized segment of view of self and of significant others as a protection against the potential for the opposite. And any frustrating experience, any negative experience immediately activates that terrible world of bad self and object representations, so that the individual does not have an integrated view of self and integrated view of significant others, tends to divide the experience of self into moments of idealization and moments of despair, inferiority and panic, and views others either as totally good and gratifying or totally bad and persecutory. In other words, a chaotic view of self and others that interferes with a realistic evaluation of the environment, interferes with good relation with significant others, interferes with normal love life, interferes with the capacity to commit oneself to work, profession, gratifying social work. These are the severe personality disorders. What are the causes of personality disorders? Two basic causes in the most simplified version. In the case of severe personality disorders, an excessive development of the negative segment of experience. And the cause of that can be multiple. Genetic, constitutional, excessive predominance of temperamental disposition to negative hyperreactivity. Deficit in the serotonergic affective system that normally has a function of calming down negative experiences, determining negative hyperreactivity. Pathological attachment experiences in which mother's functioning of normal attunement fails. She reacts to the infant's anxiety with anxiety of her own that amplifies the anxious experience of the infant and does not permit to calm that down. Or mother has an incapacity for her own problems for an affective attunement that interferes with empathy with infants or child's negative affects and creates an excessive burden and excessive activation of such negative affects. In simple terms, severe traumatic experiences, sexual abuse, physical abuse, chronic witnessing of sexual and physical abuse, the chronic distortion of generational boundaries, chaos in early family relations, particularly those that create unpredictability of the family environment. Babies and children are able to adapt to very difficult, from the outside impossible circumstances if they are predictable. It is the unpredictability that is particularly hurtful. So these are, in the simplest summary, etiological factors for which we have empirical evidence. The deficit in the transporter gene of the serotonin clearly is related to hyper-aggressive reaction to negative stimuli, just to give you one little illustration. The second major etiology is pathology of early sexual experience. That, in general, is less severe, except when it is combined, of course, with development of severe aggression, is less severe and has to do with excessive inhibition and prohibitions against normal infantile sexuality. I mentioned that the erotic system functions from infancy on, is expressed in childhood sexuality, is expressed in masturbatory behavior and in sexual fantasy, and excessive prohibition against sexuality, particularly against the activation of erotic feelings within the family circle, determine what Freud designed as Oedipal conflictuality, and is a dominant etiology of the less severe personality disorders, the higher level one that I called neurotic personality organization. Clinically, the personality disorders have been described as various constellations, of which some are clinically clearly dominant and have been described in ways that show the combination of the typical constellation of such personality traits. There are others that have been derived from empirical instruments and have clinically proved to be much less viable and realistic. So this is still controversial, but for practical purposes, I would say that the obsessive-compulsive personality, the depressive masochistic personality, the hysterical personality are personality disorders at a neurotic level in which unconscious sexual conflicts and limitations in characterological developments derived from them are a predominant etiological feature. The borderline personality disorder, the narcissistic personality disorder, the histrionic personality disorder, which is a milder form of borderline personality disorder, the antisocial personality disorder, clearly are severe personality disorders of an extroverted kind. The schizoid personality disorder, the schizotypal, more severe form of the same, the paranoid personality disorder are severe personality disorders of an introverted kind. There are some less frequent personality disorders, but clinically important one, such as hypochondriasis, which is also an introverted severe personality disorder. And the different clinical constellation that I mentioned to you clearly can be organized in terms of their degree of severity, the extent to which introversion or extroversion, which are temperamental characteristics, characterize their character structure, and the extent to which aggression predominates for all its causes in the etiology, or to what extent unconscious sexuality determines in their etiology. Practically, and this is the last point, the general treatment of personality disorder, their treatability, depends on the degree of severity, which means the extent to which identity is normal or not. We call the absence of normal identity the syndrome of identity diffusion. So identity diffusion simply means lack of integration of the concept of self, lack of integration of the concept of significant others. So severity given by presence or absence of identity, the good or bad quality of object relations that the individual has been able to achieve. I have patients with severe personality disorders who still are able to achieve intimate relations with significant others. Their prognosis is better than when that is not the case. The extent to which direct aggression is woven into the character structure, the severity of aggression directed against others and directed against self, the extent to which there is moral integrity maintained or antisocial behavior present. These are the basic prognostic features that derive, as you can see, from the various aspects of etiology and character structure that we've talked about. Thank you for your attention.
Okay, we started late. We have until 8 o'clock at the latest. And I said I was going to make some comments. I'm going to keep them very brief because I'd like the opportunity to have some back and forth here. As you hear Dr. Kernberg elaborating on this whole description of personality and personality disorders, you see that this whole way of thinking has a lot of integrity. It's complicated, but it makes sense. It's not reductionistic, however. And we have been, what you started with is something that we have been struggling with in the field for a long time. People have come from very reductionistic directions in trying to understand personality. And let me give you an example that has practical effects on all of us. The DSM, the personality disorder section of it now. It's my understanding that they were listening to therapists who've been complaining about the DSM for years, that it's too categorical, it's not dimensional. They tried to make a dimensional way of thinking about people in this DSM-5. But unfortunately, they tried to make that based on a trait theory. And the problem with trait theories, among other things, and I remember talking about this some last year here, is that when you see one trait, you tend to see the opposite trait, because what really organizes personality is not a trait, the presence or absence of something. Like, for example, paranoid people have a problem with trust itself. They are usually distrusting, but they can be pathologically over-trusting, like when they believe their cult leader is omniscient. Schizoid people will withdraw, but they have a yearning for closeness. Obsessional people tend to be terribly neat, but they have a dirty drawer somewhere. You know, people get organized around a theme, and it's the theme itself that makes the difference, not the traits. If you try to do something along the lines of the big five, this has been a problem with the DSM all the way through, so that we describe, let's say, narcissistic personality based on arrogance, when we see plenty of clinical presentations where the person has the same theme in the personality, but the presentation is depleted, miserable, I wish I could be arrogant, help me get arrogant, you know, I want to be popular, I want to be famous and rich and beautiful, and then if you can just do that for me, doctor, I'll be fine. That's the same phenomenon as the person who thinks I am famous and rich and beautiful, and I can devalue all the rest of you. It's the same personality theme, and we have called these different things in the field. Dr. Kernberg tends to talk about them as internalized object relations, which is the most common way that psychoanalysts talk about them, but they've been called inner working models by the attachment people. It's a very similar concept. Sylvan Tompkins called them nuclear scripts or nuclear scenes. They've been called representations of internalizations that have been generalized. I think that was Daniel Stern's idea. But Liborski's core conflictual relationship theme is another way of talking about the same thing. Relational patterns. Even the CBT therapists now, who have been in practice long enough to see the complexities of personality, are talking about schemas. And that's a very similar concept. So we need to have a personality theory and a way of talking about personalities that talk about something that infers what's going on internally with a person, not just what traits can be measured by very simple instruments. Not that people don't have traits, but more important for personality, they have themes. And it's one of the things that it's hard to have a conversation between clinical experienced therapists and researchers for whom it's very easy to get reliability and validity on trait measures. It's more complicated to talk about themes, but that is part of our job as therapists, is to try to talk to the research community and get them thinking in these more inferential, systemic ways. So I think that's really all I'm going to say before I'm going to open it up to people's questions. We have microphones, and we will give you a microphone so that Dr. Kernberg can hear you. And let me moderate this part of it and invite anybody with a question, a disagreement, a comment, or any other kind of reaction to talk, and then we'll engage. Dr. Takis.
Thank you very much for your presentation. I would like to ask a theoretical question. You refer to the internalization of object relations as an etiological factor for personality disorders. I would like to ask you about the role of narcissism. You have talked about some kinds of narcissism, the malignant narcissism.